Hello, everyone. A very good afternoon and warm welcome on this Saturday. I am Raghav from Healthcare Continuum, and it's my pleasure to host you in 10th in series of our Grandmaster session. This series of Grandmaster is bringing together healthcare leaders uh, in collaboration with IHMR, International Institute of Health Management and Research, Delhi. We are trying to build this as a platform where we explore the groundbreaking advancements as well as bridge the industry academia connect, as well as share learnings and knowledge with each other. It is our privilege to have our on speaker, Rajarajan sir, a very accomplished leader in the healthcare industry with 20 years plus experience. And it took a lot of while for me to summarize his little bio, but I'll try to do my best here, sir. And please excuse me if I miss any critical thing. But it is amazing to have you here. You're currently operating as Chief Operating Officer, Group Chief Operating Officer as Eluru Sitarama Raju Academy of Medical Sciences, ASRAM hospitals, overseeing a 1200 plus bed and teaching hospital with comprehensive cancer center in Andhra Pradesh. Over the years, sir has a remarkable track record in managing large corporate health organizations, focusing on hospital turnaround, profit center management, and creating value for stakeholders. His expertise includes multi-organ transplant centers and various accreditations such as JCI, NABH, UCG, USGBC, LEAD, and others. Uh, it is a very pleasure to have you, sir. And today's session, we would love to learn from you essentials of achieving business excellence in healthcare with insights into aligning KPIs, metrics, and strategies for sustainable growth and success in the sector. Your passion for people, process, and performance make you a dynamic speaker, and we look forward to have a very knowledge-packed session from you today, learning from one of the best in the business. A very welcome, sir.
Thank you very much, Mr. Goel, and thanks, Manish sir. Thanks to Healthcare Continuum, Big Podium, and Blue Tech Media, and also IHMR. It's a pleasure to be here on a Saturday afternoon. So, and we just going to straight away jump into what we're going to be talking about today. One of the key things is, healthcare has been dynamic in nature, and I keep meeting a lot of people. They keep asking the very same questions, different people, but the questions are the same. What is it that they have to do to turn around the hospitals? What are the key metrics that they need to keep abreast of? They need to keep the dashboard of. So today, that's why we just coined this nice topic called Get Well Soon, Recuperate with Your KPIs, Metrics, and Strategy. So we'll go through some of the KPIs and the metrics and what are the strategies that you need to adopt, like what you need to do right, how you can get to your benchmark levels. Those aspects would be, in a summary, would be shared with you today. It's very difficult to do this, in a nutshell, in a 1 hour session. But then we just opened up. You could connect with me on LinkedIn and other social media, and definitely we will be discussing much more offline as well on this. So thank you to the organizers, and thanks to my organization as well for allowing me to be part of this panel and talk about it. So I've been working with a lot of organizations, and I'm a member of a lot of organizations in the country and outside the country. And one thing which I always cherish is coming back and doing things for our healthcare fraternity. So that gives me a lot of pleasure and privilege. So yeah, as I said, the healthcare is so dynamic that we've come a long way. From the times of Charaka and Sushruta, the earliest documented evidences of medicine literature, to the cyber knife, to the Da Vinci systems, even to the proton therapy systems, and so forth, so on and so forth. But in all this, what is very important to actually look at is There are decades where nothing happens, and there are weeks where decades happen. You know, this is particularly true in all facets of life. Can you believe that? I'm sure many of you are cricket fans like me. Bangladesh visiting Pakistan and winning Pakistan in a two-match test series. This all happened in the last 2 weeks. Afghanistan defeating South Africa in a two-match one-day international series in Sharjah, and the second one-day international score reads Afghanistan scores more than 300 runs, and South Africa were bundled out for less than 100. So there are a lot of things. Over decades, Afghanistan might have not won against South Africa, or Bangladesh would not have won test match against Pakistan. But then in the last few weeks, all that which was accumulated over a period of time, the experience got converted into an outcome. So it is all about consistency, and no better tool to, no better thing to tell us when the pandemic was here. We were very vulnerable. We were, setting our sights on strength, sustainability, and agility, wherein as hospital administrators we were collaborating and understanding which resources available in which hospital, how we can exchange those resources between these hospitals and get on with the thing. So the important thing today is going to be, how do we develop financially and sustainably with our operations, and also bring in innovations which are required, that which should be the roadmap for healthcare to move ahead. So, as I said, innovation is one part of it, but then disruption is another part of it. So, what we have seen is disruption is real. So the thing is, if we are not ready to change, if we are not ready to look forward to these kind of disruptions and move ahead, we'll be left behind. For instance, in the 1995, around about the late 90s, we had the music, photography, video rental, which was booming. We had Napster, which democratized music, video rental. There was a company called Blockbuster. There was a company called Blockbuster, wherein they were there literally in every town, every city, every small place in the US, renting out videos. You won't believe Netflix, which is probably today about $150 billion, went to Blockbuster, talked about the idea of OTT, streaming movies, and placed an offer for $50 million way back around about 2000s. Blockbuster laughed them out. And today Blockbuster is probably there at Times Square, whereas Netflix is there at everybody's home, literally. So a lot of things over the period of time, all safe havens, industries which thought that they're not going to be affected. We know the Kodak story, we know the Yahoo story. Everything got disrupted. Do any of you know about Google in the late 90s? We don't know, but today Google is a phenom. So a lot of things have transformed. Disruption is real, and if we are not going to keep pace with it, we're going to really have a smack on our face. So change management is going to be key. And for change management, we need to understand our metrics. We need to understand our KPI. So that which is important for us to make business decisions. We generally talk about clinical decision support systems, but there is also these operational decision support systems. Data is going to be the new oil. So if we look back, as I said, in the last few decades, we have evolved a lot. India is now in the healthcare map of the world. Gone are the days when we were seen as a third world country. A lot of development, not only in healthcare, but across in various other aspects have made us into a new superpower. From patient focused care to a combination of clinical excellence and business viability is the need of the hour. So, if you look back, somewhere when we started healthcare, it was more focused on wellness. Now, we were lost in translation. We moved from wellness to illness based thing, and now we're back to the future, kind of back to the past or back to the future, where we are, trying to bring a balance between the focus towards illness and wellness aspects. Now, in all of this, the important thing is how things have evolved. For example, in China, in the late 1500s, 1600s, there were people called as the Chinese foot doctors. Now, these people were paid by the king, the king, for keeping people hale and healthy. And they did not put a clinic, they did not put a hospital and sit inside that as we are doing right away, right now. Rather, they went to everybody's house and ensured that everybody is healthy. So that's why this whole concept of Chinese food doctor came, which has now come back into home care aspects. So old wine in a new bottle. Healthcare today is data driven, which is very outcome focused. We do like our processes, but what are processes without outcomes? So we need to be very important thing here is to be performance oriented. Now, for all this, we need to integrate the business strategy with the clinical care. Now, we always say there's a lot of things. If any of the non-healthcare people come in, they would all be wondering why are we talking about healthcare as a business? Now, as per the government of India, healthcare is a private limited company. We could list the company. We are not a not-for-profit venture. So healthcare is seen as a business, and clinical care, is wherein we bring in the kind of ethics. So this marriage is going to be very key, critical, and to elevate our clinical care, we need to have better technology, expertise of doctors, brand communication. If you have best of doctors and best of technology, today you would still be lost in India because we have umpteen options. So you need to make some noise. You need to have your brand communications right. And more importantly, we need to ensure profitability and patient outcomes are together. In the recent past, we did one of the ESG exercises with Frost and Sullivan, where we talked of people, planet, productivity, and profit. That is the true meaning of ESG. It's without profitability, no company can involve itself into the ESG, other ESG related goals. Importance of KPIs in managing the balance between cost and quality is very important. There is always a cost to quality, but the cost to quality is much lesser than the cost to bad quality, poor quality. So we need to invest into this quality, but then to understand what we are investing in, what is the kind of metrics we are trying to alter with. We are not God, but we can do with a little bit of insights. So what we're going to do is what is KPIs? These are key performance indicators, this which would get accumulated into your dashboard depending upon the type of organization, your focus that you which you want to give, and it gives you a trajectory of how you're going forward. So there are financial, there are operational, clinical, patient-related metrics, and in all this data, as I said, today entire business decisions revolves around how we are managing this data, and based on this data only we can go ahead. Data sanctity, another important thing. Data structuring, data sanctity. Today, one of the most sought after things is to have data which is valid, validated, usable. So if those are the things we get onto these metrics, then our business decisions would really help in moving our organization forward. We can get well soon. Okay, so I have focused mostly on small and medium hospitals. I've given some large hospital examples also. So for some of the small and medium hospitals, your cost per discharge, your bed occupancy rate, your patient satisfaction scores are going to be very, very key. Say today, if you look at even a small rural hospital, is also looking to increase the patient satisfaction by decreasing patient wait time. The more you keep the patient inside in the hospital, the cost is higher. As healthcare professionals, we need to understand the real cost versus revenue matrix is on the first 1, 2, 3 days of a patient getting admitted and getting the intervention that he or she requires at a hospital. Beyond that, every other day, there is going to be a potential loss which needs to get added into the thing. So, cost per discharge is very important. That's why what we now advocate is reducing our loss. Today, the mantra is how to keep the hospital lights switched off and your bank registers ringing on. So that's how the entire business, there is a paradigm shift in business. So we are trying to reduce our loss. Gone are the days when a CABG, cabbage surgery, takes about 8 to 9 days for a discharge. Today it is somewhere between 5 to 6 days. There are hospitals in the West and some of the hospitals which are even talking about daycare CABG surgeries. Bed occupancy rate is going to be another important vital tool for dynamically roostering your staff members. Today, many small and medium hospitals may commit this blunder of fixing staff in some of the areas. Say, for example, they have a 10-bed ICU in this medium bedded hospital. They would assign nurses, but even if they don't have the occupancy, those nurses are not moved out. Sometimes it is not moved out because the management or the nursing leadership would not do this, or sometimes it is the other side of it where the physician, the intensivist, or the surgeon who's managing the ICU doesn't want to give away and stuff. So you always keep a cushion of the staffing and have a dynamic roostering based on your bed occupancy rate for getting better this thing. So these are important metrics for small hospitals. Patient satisfaction, we'll see about it. There are many methods through which today we are capturing the patient satisfaction. For large hospitals, on the other side of the business cycle, we look at revenue cycle. The revenue cycle management is very key. It's going to be important for the cash flow management as well. Infection control rates is very, very important. Most spoken about topic even in boardrooms today, because even if the slightest of infection, the cost for a patient is increasing, and also the kind of resources that you need to push in, monitor, and ensure that those kind of infections doesn't pass around, hospital acquired infections. So that is going to be very, very key. Today, we're talking of superbugs, MDRs, multi-drug resistant strains. So how are we as healthcare professionals looking at it? How are we setting up a proper antibiotic stewardship management program? How are we following the IPSG goals, and especially the goals of proper hand washing and related things to ensure that we keep the infection control rates low? Physician engagement. I strongly believe that the future leaders, future healthcare leaders, most of them are going to be physicians and nursing. In many of the hospitals where I've been, I have encouraging physician leadership program and nursing leadership program, because these are going to be pillars for progress, and you know that which would phenomenally move us ahead. Even a large teaching hospital cutting infection rates to strategic supply chain management. You know what mistakes hospitals do? How frequently we change our hand sanitizers? How do we see the MSDS, material specification and data sheet? And do we, over a period of every 2 years, change these things? Do we use the same thing so that resistance develop over years? Do we overuse so that resistance develop over years? How does supply chain management trigger the change into such activities on a timed period? How do we manage? How do we have a defined prophylactic antibiotic policy? How do we relook at it? How do we look at how such antibiotics are given? What are the broad spectrum given? What are the level 4, level 5, Gen 4, Gen 4, Gen 5 antibiotics given? How many antibiotics are given and stopped halfway, or just started with a dose and they change over? So all these are going to be very important when you look at some of the large hospitals, even for small and medium hospitals who have who like to bring in a phenomenal transition in the clinical management of patient care. These things go a long way. So there are hospitals today with stagnating around 60 beds percent bed occupancy. Their NPS, Net Promoter Score, also is low. Net Promoter Score is the new way of new age of taking the patient feedback. Also collaborated, combined with your frames and prompts related questions, it can really help you uh, get the real voice of customers and give you interventions based on which you can do some wonderful actions in your facility. So, like in one of the hospitals where I joined, when I joined, our Net Promoter Score, it was a fairly new hospital, started around the COVID times. We had a Net Promoter Score of 80. Now, after 2 years and 9 months, when I left that facility, our Net Promoter Score was about 93 to 95 every month, month on month. So that is a transition we brought in because we were listening to what our customers, what our patients, what our patient attendants used to say. Our facility was that good. Even a YouTube vlogger, had come and reviewed about the biryani that he had in a hospital. So the patient feedback loop and optimized bed turnaround times are very, very important. Many of the hospitals don't understand the 60% bed occupancy is not just because of patients not coming in, but also the discharge time taken or the time taken to release a bed after the discharge happens for the next patient to come and occupy. So when you address some of these things through Net Promoter Score, when you keep a close watch on that and understand what patients are saying. We had a problem because we were one of the tallest hospital in the city. So we introduced even odd in the lift management system so that we would be able to we had one lift for express services to ICUs, OT. The other two lifts were for the patient in the patient area, were even odd to take them to different floors. So better lift control using lift operators. Some of the things which we did in that hospital, which really catapulted us with respect to what we needed to do. So rising operation costs is another important thing. See what happens sometimes we get caught in this loop. So to increase patient satisfaction, we end up spending in things which does not, cost without doing the cost benefit analysis. So we end up spending more for a mere 1 point increase. Every patient feedback is important, but prioritizing it is also key. So, so what we do is, how do we see what is important? So have a clear-cut a purchase committee. Look into your capex related costs. Look into your utilization rate. You know, every hospital should have something called as a fixed asset register, wherein every capex, every capex items are listed, and for each of these capex items, especially which are associated with revenue, we are expected to have budgeting done. And based on the budgeting, we are expected to ensure we reach those targets. And the benchmark is if your budget say 100 cases and you are getting only 60%, 60 cases on that particular equipment. you are supposed to start doing a root cause analysis and what are the corrective action, preventive action from the business side of it, from the clinical side of it. Gone are the days when there is a need requirement and we find today any capex, any opex related items also we get into something called as a business justification. Even a housekeeping related consumable, we look at what is the dilution standard mentioned in the material specification data sheet. We have auto dilution equipment, auto dilution instrument dispensing units in our hospitals, wherein we monitor these things because again, this is related to your infection control. We focus so much on laundry management systems because it is a second skin. So to get your infection control, we do a lot many things which helps us in reducing the rising operational costs. Today, this information what I have put forward to you is a publicly available information. We don't know where to search for information. That is probably one of our big weakness. Data sources. So these are all publicly listed groups in the country, and year on year they would have to submit their annual report to the Ministry of Corporate Affairs. And in that website, if you go, you will see nice PDFs which you can download, wherein their operational strategy, expansion plans, everything is given. You don't have to be a strategist by doing something great. There are a lot of organizations, industry leaders who have taken a certain strategies and steps. See what is there in your bandwidth. See how you can do that differently within the available resources and costs allocated to you, budget allocated to you, and you would be doing phenomenally well. Today, if you look at Max Healthcare, the talk of the town is how their average revenue per occupied bed has catapulted above 70,000, whereas the Apollo hospitals is around 45,000. With certain recent acquisitions as well, there is definitely a lot happening with respect to acquisitions in the country. In the last 1 year, if you look at it, average acquisition rate per bed has been up to 2 crores and odd. There are some very bargain buys as well by some of the groups. Interesting, but in the next 5 years, we are seeing, there's going to be a lot of polarization. I still remember 20 years back, me sitting with two of learned gentlemen in Ahmedabad, discussing about how healthcare is going to get polarized, and we are seeing it. We are witnessing it right now. So how to correct underperforming KPIs is an art. Is an art of sustaining, is an art of living, is an art of performing, and you need to understand each of these KPIs better and what are the strategies. It's like as simple as you've added extra salt into a recipe that you're preparing. You cut some potatoes and put it. Potatoes is going to take the salt out, and still the salt content in the dish that you prepare would be lesser. It's as simple as that. I make it simple that way for you to understand. But these strategies are a series of activities. The best thing that I've seen in healthcare industry, everybody is a strategist. They can put together a strategy on a paper. But where we fail is converting this strategy into implementable points, actionable points, and delivering those. So, so we talk about process streamlining, we talk about business process reengineering, we talk about workforce training, we talk about task shifting. For instance, if you need, say, for example, as simple as, this is one of my favorite case piece that I've studied. How do you increase the number of patients that your star consultant see per day? You're going to have 10, 15 minutes for each patient. So your consultant is going to spend 10, 15 minutes. So this is the linear way of looking at this problem. Okay, so if you have 1 hour, he's going to see about 4 patients. Now, You know what Mayo did? Mayo introduced the concept of a room called Jack and Jill rooms. You can look about it. Jack and Jill. We all know it as a primary school rhymes. So Jack and Jill room are, like conjoined twins attached rooms, wherein the lead consultant can move between the rooms. His team operates on alternate rooms. Vitals are taken, history is taken, diagnostics are reviewed. So he shuttles between the rooms. So the same 10-15 minutes, for a follow-up patient, it would be 5 minutes each. And in the next room, in the Jill room, he can finish three patients in that 15 minutes. And in the primary room, which is the Jack room, he can finish about one or 1.5 patient within that. So we saw about 15 minutes per patient, patients in an hour, which could be converted into about four patients into 15 minutes, and you can have a throughput of 16 patients in an hour. So it's all about the structure, the design, the strategy, and Mayo got it right. So rapid process automation, this is another way of looking at things. What is it? See, the thing is today, as I said, data. Source capture is very important. Many hospitals, including the very hospital that I am currently in, were capturing data in a different way, in papers, in this thing. Now we are getting it all digitized and we are getting into source capture. Earlier, there were no shared resources wherein each of these people were doing the length and breadth of one particular activity rather than doing a source capture and transferring as a relay race. There is a fear factor. What if one team misses out on collecting an important document? This is where the way how you need to strengthen your digital systems comes into play. What are the mandatory documents for each of the corporate during admission? What are the mandatory documents for each of the? It is all one-time configuration that which would give you, phenomenal results over time and again. So rapid process automation is phenomenally, changing the way we are doing things in hospitals now. Another very, very favorite activity of mine in any hospital is to start the crew or wow related project. So crew is typically cost reduction and elimination of wastage. Wow is war on wastage. There are other acronyms and mnemonics and various other things related to this, but I'm sure you got the gist of it. So what you're doing is there are, if you see, there are three types of Mura and Muri related things. Then you have the mnemonics of Tim Woods, time, inventory, and various other things. What are all the 8 types of waste and stuff? How do you avoid each of this waste? So those incorporated into hospitals is, will give you phenomenal results. uh, Using WISN to understand your staffing requirements would help you optimize your staffing needs. Bringing shared resources optimizes your staffing needs. The very famous example or project which many of the students take up is the radiology film wastage. This is another classic example of crew cost reduction and elimination of wastage. So there are a lot of cost reduction crew projects, wow projects that which you can do in hospital. Even taking your 80 percentage, taking your A cost items, renegotiating the supplier contracts, renegotiating the AMCs and CMCs. We did that during the COVID, pre-COVID, during COVID and post-COVID. We had phenomenal discussions with vendors where AMC, CMCs were renegotiated, even supply spares were renegotiated. They were also very, very, considerate big corporate companies, and the benefits were passed on to the organization and even the patients at times. Today we talk of even for effective utilization, we don't not only talk of rental reagent model. We now talk of ownership transfer models. So ownership transfer model, say in one of the organizations which we were working, we did not buy the ultrasound equipment. We used the ultrasound equipment, and for every ultrasound that we did, for a minimum number of ultrasounds per month, we need to pay that X amount to the organization which had given us. In 5 years, or with a milestone number achieved, this principal organization, which is a manufacturing one of the OEMs, will transfer the ownership of that equipment back to the hospital. So there are a lot of things you can do with negotiating a supplier contract. It is as simple as understanding where you're outsourcing your laboratory tests and renegotiating. Understanding which are the tests you can do inside and which are the tests you need to outsource due to viability related factors. So all these would definitely increase your operating margins. Clinically, if you look at mortality rate, infection rate, readmission rate, as I said, healthcare costs, today we are at the juxtaposition of what we call transitioning from evidence-based medicine to value-based healthcare. Evidence-based healthcare to value-based healthcare. So what we currently practice is evidence-based healthcare. We do diagnosis, we diagnose what is the thing, we start with a broad treatment, but then once the diagnosis is ready, ping on to it and do the differential treatment and get the curative thing or maintain for other chronic cases. So in this point of time, value-based healthcare, I was working in Indonesia. We had this scheme called BPJS, very similar to Ayushman Bharat. And in that, and even in Ayushman Bharat, it might be similar thing. In that, if a typhoid patient gets admitted for 3 days or 30 days, the reimbursement from the government is going to be the same through the scheme. For instance, I've been working in many of the multi-organ transplant centers. So the government schemes provide the package rate not just for the intervention and the surgery, but a 1 year or a two, even sometimes 2 year maintenance period of the patient for their all the follow-ups, their medications and stuff. So whether we know it or not, we are moving it into value-based healthcare. So this is wherein the operating margins become very vital, very much key to sustain healthcare. Today, many of the small organizations are caught in this cycle of schemes and certain other bad payers, wherein they've not got their amounts released for years together or for months together. So it's all going to be important how you manage all these things. So very many clinical KPIs are there. As a very young executive back in the time, 2004, 2005, in Apollo hospitals in Ahmedabad, Apollo started something called as ACE25. It was little before even NABH had come in. I think the following year, 2006, 2007, probably is when NABH movement started in the country. But ACE25 talked about Apollo clinical excellence. I still remember I have a copy of that mail which we had got from the corporate office from Chennai, and some of these things which we are talking over there, this and some things like ventilator associated pneumonia, catheter associated pneumonia, and various other things were beautifully captured. Month on month, we get this beautiful spider diagram of how different units were performing. There was a lot of exchange of best practices between units. Today, I'm sure many of the big corporates and healthcare organizations are doing that. The same thing, if you look at it from the NABH point of view or even the NABL point of view for lab tests, we have something called as a EQUAS, External Quality Assessment Survey. So that is also, important metrics for hospitals to look at where their test accuracies are. How do we reduce the readmission rate? How do we reduce the re-exploration rate? How within 24 hours, how many patients came back? 24 to 48 hours, how many patients came back to get admitted? Within 30 days, how many patients came back to get admitted for the same problem? That is why NABH6 has made it mandatory to capture patient-reported outcome measures. The important thing for you to capture even at the time of admission is what is it that the patient has come for, and in your discharge summary to mention that they have been alleviated of that. So that is which very important. And even bringing in the discharge follow-ups, telemedicine. I was talking to my team 2 days back of how we were doing in some of the corporate hospitals where I was working. Patients who came to the ER and left without getting admitted, or just as an OP for ER, we call them back the next day, check with them, how are you? We do this with all our relatives when we get to know that, or even friends, when we get to know that they are not well, or somebody in the family is unwell. We generally, Atithi Devo Bhava, we always take care of people around us. That's imbibed in an Indian culture. So that's the same thing. We need to bring it together into our hospitals, into our teams, to call back. And I was just telling them, don't please call broad dead cases and ask how are they and stuff. So choosing, making the right thing. This particular thing, I would definitely urge you all to read this book. If Disney ran your hospital, nine and a half things that they would do differently. So Fred Lee was running Disneyland for 20 years. After that, he came to a hospital, healthcare, and he was the CEO of a big, large healthcare corporation. And one of the things is this post-discharge feedback call, not only for the patient who are IP'd and discharged, but also for the patient who are left here. Your two important gateways are your OP and your ER. So get it right, team. Get it right, fraternity. Okay, ALOS, we talked about it, bed occupancy rate, time to treatment. Uh, this is very, there were indicators which were in what time the patient came to the ward and the nursing assessments were started. We measure that. What time the patient came to the ward and the doctor met the patient and initiated treatment. We measure that. So these are all also important metrics to increase efficiency. And there are a lot of that is where another thing which we would like to talk about is ISBAR, ISBAR forms, the handover related thing, which generally helps the way care is provided in our healthcare settings. So all this, when it is implemented in small, and all these things, what I'm saying is not going to cost you. Today, even RPAs, many startups have come. They've come up with some of the POC models. Small hospitals, medium hospitals should actually look out for some of these startups who are looking for proof of concept testing sites. You would be able to get these into your system. As I said, we have the NPS. Gone are the days when we do the paper pencil test. But yeah, HCAPS is another successful way of capturing it. The TAT is a very, very important thing. So we were looking at that time for consultation. Every hospital kind of measures it because we need it to be submitted for a quality indicator if you are with NABH or any other accreditation agencies. But what about the tag for various other services in certain other settings? What about the time taken for a patient, inpatient, to get their demands fulfilled? What are those demands? In one of the hospital, what we did was we mapped all that an inpatient would ask. They will ask for say a mosquito coil. They will ask for a extra pillow, extra bed sheet, newspaper, food. How do we digitize all this? How do we reduce the tax? How do we make people not responsible but accountable? The key word here is accountable. How do you move your team to deliver this kind of service? So the transition was very evident. These are all the success stories to move from 80 to 95. How do we still be sustainable? by providing digital newspaper. You want one newspaper, we give you 3,000 newspaper. We tied up with an agency called Maxter, and we were one of the very first in the healthcare industry in the south to have done that at that point of time. So queue management systems. Today, we just don't talk about queue management systems in isolation. We talk of queue management system TVs in the waiting areas, along with breakers and branding stories. How many of you have gone to the railway station? The railway station, we see this huge, large display of train arrival and departure. Long time ago, only that would be played on this screen. Today, these are all LED screens, upgraded, centrally controlled. They play it for probably 20, 30 seconds, and then they change over to some other thing, advertisement, talking about IRCTC, talking about Indian Railways, talking about some of the government schemes, talking about some of the advertisement revenue also they're getting out of it. So why not bring that into hospital? So we are now doing all this in hospital. We are getting better appointment management. We'll be looking at even the CRM thing. Today, we don't let a OP patient or an IP patient move out of the hospital without their follow-up date hard-coded into the HIMS system. And the HIMS system would trigger 3 days prior or even 1 week prior, depending upon condition, depending upon the treatment, depending upon various other factors, and our CRM team would call them, schedule the appointment or reschedule, push the appointment, this side, that side. Appointment management is a science. In some of the hospitals that I work, appointment management in the morning is only given to walk-in patients and new patients. All the other scheduled appointment for follow-up patients is only done in the afternoon. Why do we do that? There is a science behind it. Patients who are coming in the morning as new patients or walk-in patients, they have something far more important to get attended to. We get them to do the test, and by the same day evening, we could start them on some of the based on some of the findings that we have. Your follow-up patient is also going to come with the diagnostics because they know when they come for follow-up, they have to finish those diagnostics and come. Still evidence-based medicine, my dear friends. So that way, this small trick could help you increase the way you are seeing how flow is into your hospital. You know, long waiting time, low patient satisfaction score. Introducing, as I said, bringing these digital display systems makes consumers feel that they are lesser, the 33% decreased perceived wait time. Isn't that better? So an informed system with these breakers, with these branding, it is also going to do a world of good to your organization as such. So operating margin is going to be the key. We talk about it in various ways and various cases, but this is going to be key so that business can be sustainable. Revenue per patient, as I said, ARPOB, or even average revenue per patient in outpatient, in inpatient, all these key metrics are being taken. Cost per case. What is the actual cost? When I say cost, the biggest thin ice that many of us stand in healthcare organization is because we don't do costing. We don't do ABC, activity based costing. What we do is, what we end up doing is market plus costing, market plus or minus costing. Oh, XYZ hospital is this. They are the market leaders, so they charge 100. I will do 95 rupees. You know, it's not new in healthcare industry, and we are not the first to do this. For example, if say you're getting a Tata someone Sampan dal or something, the Amazon brand or the Flipkart brand of it would be 5 rupees lesser than the premier brands of food products, FMCG products. So, but they all do this market plus market minus related costing. not costing, pricing rather. So how do we increase revenue per patient through optimized service pricing and bundling? When I say bundling, packaging. How do we put package gains back into the process? So these are all signs that you all need to get into, and since it is very detailed, I can't do justice by talking about it in just 2 3 minutes, but we'll connect on these. Another important thing, as I said, service bundling. See, today the important thing is what we did in one of the organization is we saw that some of the PSU related companies and their reimbursement, their rules and regulation, how do we hard code it into the system? How do we run approvals? Automate how do we automate requests for approvals to the principals? So all these were done so that what we had was better service bundling. Whatever we eventually gave the bill for, we got complete bill approved without disallowances, without deductions, which is going to be. How many of you go back and see what is the disallowance and what is the deductions in the bill? It is very important. There are ways and means to reprogram this into your cost systems and present it, brand it in a different way, and still insurance or corporates, they're going to end up paying that. Because today we are not branding it rightly. It includes all those 22 related standard deduction items given by GIPSA. So you need to know the science behind all this, and you can do that. So all these are going to, there are ways and means of increasing your EBITDA. Today, we don't account for the patient ID tag. You might be buying that patient ID tag and putting it. You are storing those patient ID tags. You are having people collect it, store it, put it. There is manpower cost, there's overhead cost, there is a inventory holding cost. What about all those? So how much is the right charge to charge for a patient ID band? Because your IPSD goal 1 states that, what does it state? Identification of patient is important in more than one form, 2 ways. How are you going to do that? So patient ID band is important, but many small and medium hospitals, for the cost of it, don't include it. Understand your cost, transfer of cost to the patient, because it is for patient safety. Similarly, the medical records file. We have the MRD charges. You are documenting all these papers. Now, many hospitals are going to EMR, which is a welcome sign. Even I see some of the small hospitals going into that, which is fantastic. Other than that, that is what the government wants us also to do, because government is working on a much larger scale of bringing in Ayushman Bharat Health Mission, Ayushman Bharat Digital Mission. If you want to know more about what we will be getting into, just look up Malafi in the Middle East. We are talking of how do we access the longitudinal healthcare data of a patient. We are talking about mapping every hospital, mapping every doctor, and mapping every patient, and understanding the performance metrics at the government level. And that is a true EHR. Okay, many people do ask, what is an EHR? What is an EMR? EHR is large. EHR is derived with a huge data lake of information, which has been encrypted and available for research and all the stuff, and that data sharing and stuff. That's what we are getting to, my friends. So when it comes to HR, you talk about turnover rate, staff engagement, training hours per employee, which is very, very key. If you don't train your employee, you're not going to get the desired outcome. If you don't train your employee that they have to fill a manpower requisition, you're going to end up getting emails or letters by them and stuff in an unstructured data. How do we make it structured digital data? That is going to be key. So how do we reduce your staff turnover? Town halls, organizational climate survey. How do you engage with your employees? During the COVID period, a lot of hospitals, in one of the hospitals where I was, We had this thing of preparing a patient favorite food from home, collecting it and putting it into the giving it into the patient room. But what about our staff? So we started a program called HRU. How are you? So the engagement program was very, very important to keep the burnout. But then many of the companies which did these kind of engagement programs have forgotten it during after the COVID times or the pandemic times. But this has to sustain over a period of time. You will see reduction in turnover. You will see increase in staff engagement. You will see more productive staff. Today we talk of something a concept called micro habits. To tell one negative connotation, micro habit. People who need to have a sutta with chai in between breaks, a couple of times or 3 times or 4 times in a day. We have these kind of people in our healthcare system sitting in the hospital, taking their own break and coming out. It's a micro habit in a negative connotation. But similarly, look at it in a positive connotation. How do we make our staff acknowledge the patient or the attendant standing across the table? How do we make them stand up and receive document? How do we imbibe this into hard code these into the DNA? So that is going to be very, very important. How are we going to make it worthwhile? How do we going to drive the purpose into them? And how are we going to get the difference? That is going to be key. This is going to be, I will suggest a book also. That book is called as Hardwiring Excellence by Quinn Studer. Fantastic thing. If you read that, your thing of staff management can be really it's not no more a nightmare. Inventory turnover, cost of supply per item, procurement time. There are organizations which have phenomenally worked on this. When I've met with many of the industry leaders and when we talk about, when I come from a high volume, high multi organ transplant center, when we talk, and although in a major city, we talk about the inventory holding cost, we talk about what is your material cost, I was shocked when they said it is about 24-25%. It's a large corporation. We will see an example about them. But the truth is, it can be done. Just in time is just not in the theory books. It can be done. But what do? We stock items. Stockpile creates even obsolescence. Near expiry management is another work. That's where in your lean management systems should come in. Tools like Kanban can be implemented. So many things are there. This is how you change the metrics, you change your obsolescence, you change your losses, your near expiry. How do you take it out of your system? How do we talk to your suppliers and say that near expiry return and replacement of the product? It has to be into the SLA of the vendor arrangement or the rate contract that you're putting with them. High inventory cost, long procurement cycle, because ABC is not done. Minimum order economic order quantity is not known. All these relates to problems. So understand the science behind all this, become Scientologists in the right way, not in a religious way, in the right way for healthcare, and definitely you will see differences with your metrics. CRM is a phenomenal tool. You can look at patient retention rate, conversion rate, lifetime value of a patient. One of my founders of this large corporation of the largest cancer chain in the country always talks of a lifetime of a patient, value of a patient. He advises us to be considerate to them, give them discounts because they have spent the entire cycle, because the cancer is not just a one visit cure kind of a disease. So the kind of, and he was also one of the first to talk in detail to me about the value-based healthcare system. So I always cherish those discussions we've had. So this lifetime value of a patient is going to be a very critical thing. Lifetime cost of an equipment is also another critical thing you need to have in your metrics. What is the AMC CMC? What is your breakdown expenses? So coming back to CRM, making use of all this, patient retention is nothing but the patient journey management. How do you know, okay, how many patients are coming to your OP? Out of those patients, how many patients do buy medications at your pharmacy? Why they should buy from your pharmacy? Please educate them. How many contra brands are there out in the market? How many people are giving medicines without even maintaining the cold chain aspects of it? When I was dispensing medicines in one of my corporate hospitals, patients were
Thank you, sir.
surprised that patients were surprised we were putting these medicines in with ice pack and giving it to them because they were buying it elsewhere without even getting the ice packs and the cold chain management in place. How do these items are stocked in those stockpiles? Is it done in cold chain systems? Your efficacy of vaccines is nothing if it is not maintained in cold chain systems. So all these are going to be very important. So making patients understand why they have to buy medicines in your hospital, because as a hospital you take care of all this. Why should a patient do diagnostics with you? For example, a patient in a hospital who goes for an MRI spends 40 to 45 minutes on the couch in the MRI. Whereas a patient who is going for the same MRI brain in a diagnostic center might spend, okay, 10 to 15 minutes on the couch. Why? Because diagnostic center, based on the finding they want to do, requested by the clinician who has sent the patient, would run 5 to 6 sequences and do the reporting. Whereas the hospital would have to go through the entire 11 or 12, how many ever sequences of MRI brain is there to complete it. We do fishing in the ocean. They do fishing in a pond. It takes time. Machine time is higher. Today, if you want to know why diagnostic company versus hospital treatment cost is a little different, it is because of all this. So similarly, I can tell you examples in lab as well. So it's very important to retain all these patients. Even a patient who is coming to ER, I keep telling my doctors, please don't tell any patient it is for observation we are keeping it. Observation in emergency is a taboo word. Let us get it straight, my friends. Please go back and educate your teams. We are there to provide treatment. We need to see what is it on an evidence-based management. By giving this word observation, patients are running away. Rephrase it, get them to stay back, ensure that they are fine before you send them off. Provide extended care for against medical advice patient. Give a clear handout to them about the condition and stuff, even if they go from your hospital to another hospital with a dozens of inotropes plugged into them. So all these are going to be very vital. Small things makes a big difference. Okay, so there are umpteen number of CRM systems, Salesforce. There are a lot of systems in Zoho. There is Lead Square. So many of these systems we call these as funnel management system. From lead to final patient engagement. From even before the patient is coming into your system to the time patient takes the treatment and gets out of your system, how do you still engage them? Can entirely manage by putting your infrastructure right, having your right CRM for your call center, having your right CRM for your marketing with all integrations from your website, with from your chatbot, and having your integration into your HIMS and EMR, and having your integration with your WhatsApp and SMS and email bots. So this is the true thing. You will see the lifetime journey of a patient. Organizations which have put this together are reaping benefits. Why aren't you? There are cheaper methods of doing it. And there are certain companies which are giving patient-based costing as well. So you need to look at the right places to increase your patient engagement, to increase your repeat visit rates, to keep them engaged, to keep them in your system. That's where. What is the contact rate? Today we all talk of SEO, SEM, click-based targeting, whatnot. Okay, what is your contact rate? How much do you spend to make it into the eyeball of the patient, or to the awareness level of the patient or the attendant who's taking the decision. What is the referral rate? What is the chance based on that awareness or the eyeball view that they've had, they are going to come into your system? What is the acquisition cost of this cycle? What is it that you're going to do for retention? For example, we use one tool called Effort Plan. Okay, Effort Plan and even Bajaj Health also we use. So these gave us, we gave them 10% cash back through a card wherein they were able to use it back in our own healthcare system. Effort Plan had the gridlock. So if a patient spends 100 rupees in my hospital, 10 rupees goes back and sits in his wallet. Next time he comes, if he wants to take a service for 120, he pays 110 rupees. This 10 rupees is added to that. 120 and 12 rupees goes back to his wallet. Over an inactivity over 1 year, whatever is that inactive amount is transferred back to the hospital. Isn't it super? Why aren't hospitals using these wonderful tools? Because of awareness. Increasing patient loyalty would increase revenue. Patient loyalty is not just also by transparency, but also by schemes. You need to be transparent. You need to be ethical, but also introduce these kind of patient-friendly schemes through which they will be engaging with you. If you look at the large organizations have been able to increase the market share. Even if you talk of the market leaders, their market share was as less as 10%. Focus on patient-centric care over the last decade, expanded digital health services. We talk of 24/7. They're one of the big thing, and the kind of evaluation it has got and the investments it has got. So their market share has increased to 18%. Digital consultation. I belong to Telemedicine Society of India. Telemedicine Society of India was formed in 2000. Only in 2021, when we had this, whenever we had this COVID phase 1 breakout, on 25th of March, we had this first telemedicine practice guidelines coming into play. Today, we have a government-driven system called e-Sanjeevani, which through all its aims, reaching out to millions and millions of people. Many of the corporates are still utilizing the telehealth also for the ORCs, not only reaching out to the patient, but also becoming carbon conscious organizations. You don't have to send your doctors in diesel driven cars or petrol driven cars all the way to the ORC center, but you can do it via telehealth and reduce the carbon footprint of your organization. So fantastic things are there. We just need to know. So electronic health records, we talked about it. That's going to be the future. AI is something, AI is just one small topic, but if you get deep, we can talk many such examples in teleradiology. We use one technology called Cure AI to do scan on our regular chest X-ray, which is coming in our health check department. We found anomalies in some of those scans, and my doctor radiologist reporting time for each of this reduced from 5 minutes to 2 minutes, because the 2022 parts which positions or some things which has to be screened, it already screens based on its machine learning, based on AI, based on all the data that it's available with it, and gives the anomaly report. And we were able to save lives. We were able to look at lung cancers through chest x-rays, further confirmed with other diagnoses, still an evidence-based management system. So, long story short, we save lives, making a difference. So the adoption rate is going to be very key. So we keep measuring how much of, in this, for the OP part of it, we call it as CPOE, computerized physician order entry. So how much of physician order with respect to prescription, with respect to diagnostics, the customer has fulfilled. Okay, or how much of our doctors do the EMR process. So without the EMR process, you're not going to have your business opportunity. Loss? You cannot set a SWAT team, special weapon and artillery team, who would make phone calls, send in teams to take the samples or schedule their MRIs and CTs the next day to get them back into the system. So all these are going to be very, very, very key to transform this thing. In HCG, I was part of the EMR implementation in the flagship unit, and believe me, in 3 months we had about 80% utilization. The kind of thing, and also we around about the same time we introduced the digital pathology systems. So, wherein not only subspecialization in oncology, organ base was reached with respect to the clinical specialties, but our laboratory doctors started becoming subspecialized. So, all this made a phenomenal transition. These KPIs are very important. It depends upon where are you. Okay, based on that, what you need to do, how can you bring in digital patient retention models into your system, patient journey management system? How can you reduce cost? How can you get the efficiency in gains? We talked of package gains. When you set a package, the biggest blunder many of you people we do is, including me, in my very first job, we found out that every time a particular doctor does a particular surgery, we end up losing 5,000. We want to increase the surgery numbers. We want to get more market share. We want to make a difference in multiple patients and their families. But every time they do that, it is at the cost of the organization and for an average loss cost of 5,000. Then we adjusted the limits of pharmacy, limits of consumables. We defined package definition is a science of its own. And then whatever is okay, we have given 5,000 for laboratory, they've used only 4,000. The 1,000 would cascade and flow down to other areas where it is required. That is package gains. We started something called as a cost guarantee certificate, and we gave away 100 coupons of total knee replacement in one other organization which we started. And 100 TKR, every patient paid that fixed amount. And end of the day, if our costing was lesser, we called them, and though it was packaged to X amount, we said, okay, 2,500 was excess, so we are returning back. Though it is a package, we're returning back. The kind of goodwill it gave us in that market was phenomenal, unparalleled. So, how do we piece it all together? The clinical, operational, financial, HR, and the digital related adoption KPIs are all interconnected. You can improve patient care, you can reduce staff attrition, you can better the financial performance. You need to connect it. For everybody it's their own, but you need to understand the science, then you can do this. So the role of each of us as leaders or as aspiring leaders is, how do we orchestrate this into a perfect symphony? Okay, so there are very many things which I could keep talking. I'm going to be sharing this presentation with the organizers, with Healthcare Continuum, with Goelji and Manish Rastogiji. We are going to blast this to all your registered emails so that you could have a better understanding or a reference point of it whenever you want to refer to it and connect with us. In my introduction slide, all my social media handles are already hard coded. If you click on any of those buttons, you'll be able to get in touch with me, and I'll be happy to connect with you offline and take it forward. Being a Saturday, being also a family day, a little in the evening, I'm trying to run around with the slides to take you to the final few slides. So how do we as I said, Hridayalaya was Narayana Health is a company which has about 24-25 percentage of their inventory costs. So that which means they're straight away adding about 4 to 5 percentage into their EBITDA. Usually, I see organizations between 26 to 28. There are certain organizations at 28 to 32 based on what kind of market that they serve to. Sometimes when you use all innovator molecules or even high end, high brand implants and things, your margins is reduced. Okay, AI, we've spoken about it. Today, you can really use the power of AI. You can understand the price elasticity. I always tell my supply chain management folks to get me one particular letter, the authentication letter by the principals that the vendor is the distributor. Vendor is the whole say the only distributor or the distributor, because I don't want to buy lower than them in the supply chain, because then my cost, what I'm paying, is going to increase. So if I buy from the person above, I might only pay about 80 rupees. But if I'm going to buy it from a next level person or the lower level chain person in this value chain, I'm going to be paying even 90 rupees or 100 rupees for a 120 rupees product. So all this is very important, and all these can be fixed, hard coded, and now today you have AI related tools also to do the study and let you all know what you can change, transform in each of your organization. So cross-functional collaboration is the key factor for business excellence. Let each of it not function as independent islands, because it's of no good. We need to piece it together. We need to bring in these multiple disciplinary teams to work together so that we can really integrate this and get the best results for the organization. Okay, so if you look at Fortis Escorts, the way they started, the way they put the leadership in cardiology, and Fortis was one of the first hospitals in the private sector probably to put the clinical outcomes on the website and stuff. Even today, some of the hospitals we think about it. So the thing is, to be a leader, you don't have to do different things. You need to do things differently. So understand your KPIs. Get it all together for long-term business excellence. Cross-functional collaboration is going to be key to change these metrics. Leadership effectiveness is all about getting your dashboard right. The way your promoters, the way your stakeholders would like to see it. You are operating on a six market thing. You can look into the six market theory to know more about it. So every successful organization is now looking into these. They are all still trying to better these. Now, how each of you are going to piece it together for your organization, and be it at a very regional level or a national level or at an international level, it is all up to us. Understanding the science behind these metrics, what what is, what if, what was, what works, building in, bringing in some of my favorite design thinking aspects into it would definitely transform how these KPIs are driven long term, and that which would benefit the organization for good. So you can leverage technology, which we have already spoken about, and personalized medicine, advanced diagnostics, patient-centric care, all of it stems from data, piecing these data together from these multiple diverse fields together. Okay, so with this, I just would like to open the floor for some questions, and if anybody would like to share any experience or insights also, it would be good. But I strongly believe on one thing, or rather, two, three things. It is wrong to suppose that if you can't measure it, you can't manage it. It's a costly myth. It's told by none other than Edwards Deming much later in his life. But often in many of the programs that I attend, especially related to quality or those kind of things, we talk about you can't manage what you can't measure. So that was early phase when Edward Deming became even more wiser, even more lot of gray hair and stuff. He said that not everything can be measured. So it's about human emotions, It's about understanding what people want. It's about user centricity, patient centricity, and delivering results. And you can do it. You can do it individually. You can do it with a small group of people also, because that's the only thing that has changed the world. Margaret Mead, a wonderful anthropologist, has said this. And as I said, some of the books which I really urge you all to, at least get a Kindle or a digital copy of it and read is Hardwiring Excellence by Quinn Studer. What Got You Here Won't Get You There by Marshall Goldsmith. And If Disney Ran Your Hospital, 9.5 things that you would do it differently by Fred Lee. They summarize in that book, they summarize 10 action points. One of it is the post discharge calls as well. 10 action points. You just Google today, ask Dr. Google to tell you the gist of if Disney ran your hospitals. It will tell you that 9.5 things. So thank you very much. So some of the things when I share it, you'll have all this. You know what you can Google about and what you can get from these things and stuff. So thank you very much. I'm open to questions now.
Thank you very much, sir, for taking us through. I know so many case studies. We wish we could learn more, but I know we have a limited time with you and you have a very packed schedule. But thanks again for walking us through. Maybe we'll keep it short, maybe some few questions anyone would like to ask. Any thoughts they would like to reflect, please feel free to unmute or type in chat. Soumyakanta ji, any question? I think you're on mute, sir.
Hi, Rajarajan ji. Indeed, excellent talk. And a operational champion can talk like that. And the lot of takeaway points you have mentioned, and one of them is the supply chain management, which you are giving a lot of stress on that. And this is a good takeaway for many people. I just need some advices from you regarding the discharge processes, because that is one of these satisfaction point where it creates a lot of issue, and it is a boiling point every hospital faces. I just want to share with you in my hospital. You and me work in the same medical institute. You work in the ASRAM group, and I am here in KIMS. Here we discharge around 7,000 patients per month. And my real problem is my plant discharge is only 29%. And my average discharge timing goes as high as around 3.7 to 3.9 hours. So what do you suggest to do to bring it down?
Okay, so when you look at discharges, we make a very big mistake by saying 3.7 to 3.9, because this is an average discharge time. Discharge time.
Yeah.
What we need to look at is not the average discharge stat. We need to start looking at the outliers. Okay. Another great book called Outliers. If you want to understand the importance of outliers, there's a book called Outliers. You can look at it. So outliers are very important. It's those outliers which is increasing your TAT. So understand your outliers, Mark, and what is mistake. Go back to your system and correct each of fix that time for each of your processes from doctor intubation. You could do some task shifting. You could do some digital adoption in this. You could do some push of a button in a mobile app for a doctor. You could do that. And many of the hospitals, another big mistake we do it is, we do it from the other side of the funnel. Oh, discharges are happening delayed. Then we fix that. Then we move back to another step and say that, okay, planned discharge can make it better. Actually, we have to fix it from the other end of it. We have to fix discharges from the admission side of things. When a patient is getting admitted, we have hard-coded in our hospital, expected date of discharge is mandatory. Not only for electives, but for all cases. Even if it is a trauma-related case. Let them put based on doctor's assessment, even if it is a medical case. Okay, let them put this. So what happens is, we have a discharge specialist. Discharge specialist role is to look at all this that, okay, 150 patients have got admitted, 200, because as medical institutions, we have in triple digit. So how many other patients who have got admitted, we need to know that all the expected discharge date is put in. Second aspect is, what are those discharge related processes which need not happen at the last day? I'll tell you 2 or 3 things. Your OT clearance. Okay.
Right.
So what we have done is OT clearance, 24 hours outside the OT clearances has to be completed. The major problem is when implants or stents, or, cap clearance, OT clearance, all in the same line.
Agree. Yeah.
So what we have done is, when the vendor is coming and giving the delivery challan, he is giving, say, in this thing, he is giving 6.5, 7, 7.5, different inches, different centimeters, whatever. He is going to mention the price, including GST, whatever it is, at the back of it.
Right.
In pencil. So
Yeah.
my billing team, my OT team will incorporate that amount. I am not worried whether my supply chain team have got the invoice at the time of discharge, but rather what we have done is, on the same day evening, we notify the vendor. Within
Okay.
24 hours, we get the invoice as well in the working day.
Yeah.
Now all vendors work even on Sundays for that matter. So we get the invoice. So we are now talking of one of the concepts which I said, task shifting. Some of the tasks that you have in the end point, you're shifting to before. So by shifting it before, you're able to get in efficiencies into your system. Another area is your discharge summary. Okay, discharge summary, in one of the hospital, we had a discharge summary time alone as 2.5 hours. It was a critical pathway. When we did the critical pathway method, we analyzed that, and we found out that discharge summary is going to be a major mistake. So when we went for the EMR and we went for voice-based discharge, it was in HCG. What we did was, we considerably reduced this into half an hour.
Yeah.
Because with the EMR, the discharge summary was getting accumulated on a daily basis. At the end, they don't have to piece together all the diagnostics. They don't have to type the history on presenting illness. All the OT notes, the anesthesia notes, all those things are pre-entered. It is received from different places. Again, task shifting. Got it all done. So what happened on the day of discharge? It is just mere this thing, and the doctor see it on the mobile. They dictate voice, fifth line, third word, spelling mistake. Over, it will come. Only the final discharge related thing is given. And then we standardize the in case of emergency thing also.
Yeah.
Because the problem is, in many hospitals, each department would give different mobile numbers, and then the doctors might go away, or the staff whose number is given goes away. We might have not got a CUG number. You lose your patient retention, you lose your patient engagement also.
Yeah.
So all this has to be seen in complement. So there are 25, 30 different things that you can do right in discharge, and you can reduce it. Okay, we'll connect offline. I've given
Thank you. We'll connect offline. Thank you. So nice of you.
Yeah, definitely.
I think we'll take the questions offline. Feel free to type in the chat and we'll coordinate with sir to get responses.
Yes, sir.
I would just take a couple of minutes to share couple of strategic announcement. I think Rajarajan sir, you mentioned that India is no more lagging behind in the healthcare. We are coming up, and with that spirit, we at Healthcare Continuum would like to share this exciting news that last week we had our strategic collaboration signed up with an international statistical brand, Statista, to take a data-driven approach to rank and rate Indian hospitals in the global standard. So the rating is developed with the global standard and provide a 3 to 5 star rating, a 1 to 5 star rating, and hospital gets opportunity to take this rating, getting featured in Statista Newsweek, one of the premier media publication, to compete at the global level with this rating. So very glad and very excited to have this session as a bridging to that concept about data-driven approach. And with that, I quickly just move on to next announcement about upcoming masterclass on 20th September with Colonel Hemraj Singh Parmar, retired Colonel. Sir is founder of Ayush Pay, a healthcare fintech company, and we'll send across the link for registration after the session today. So we look forward to see many of you. And in case you have any questions and inquiry, feel free to reach out. So I'll now request Manish sir to share a few words and we can conclude the session. Sir, you're on mute.
Well, thank you so much, Rajarajan. It was excellent, very insightful, and very action-packed presentation. And I'm sure it was, I would say, like it's a super grand, a lot of insights. It shows like the organizations you serve and kind of learning you have had across all those, across your journey in healthcare. I mean, I'm delighted to the course. And as I said earlier, probably time permits, I would like to listen more and more from you. Yeah, maybe something live in coming year. So thank you so much.
Thank you very much.
Absolutely. I know a lot of participants have a lot of wonderful comments in the chat and a lot of questions as well, because sir, you really pushed on certain very different optics of looking at healthcare business. So I'm sure they would reach out to you offline and we'll share the recordings and the file by coordinating with sir and on your email ID, registered email ID. But thanks again for staying till last and engaging through this session. And thanks very much, sir, once again. And with that, we'll conclude the session for today. Thank you, everyone.
And thank you.